So let's get started. Okay, so welcome back to our podcast. I'm your host, Macy Levan, and today we'll be diving into a very important and timely topic. These new classes of diabetes medications, they're SGLT2 inhibitors and GLP-1 receptor agonists, and how they may change outcomes for kidney transplant recipients. Joining me is Dr. Leo Riella, a leading transplant nephrologist and researcher who recently co-authored a systematic review and meta-analysis on the subject for the Transplantation Journal. So welcome, Dr. Riella. Thanks for joining me.
Thank you so much, Macy. My pleasure to be with you.
So let's start with the big picture here. Kidney transplant patients do so much better than if they remained on dialysis, even after that transplant, right? But they do face some long-term potential complications such as cardiovascular disease, diabetes, allograft dysfunction. Can you walk us through why these are such persistent challenges in transplant patients?
Of course. So we think about a lot about rejection as being, a leading cause of transplant loss. But in reality, even though rejection contributes to transplant loss or shortening the life of the kidney transplant, a lot of our patients are actually going to die with a functioning kidney transplant, meaning that their comorbidities that have been accumulated over the years, plus some of the side effects related to immune suppressive drugs, can have a huge impact into their lifespan by impacting other diseases such as cardiovascular disease, by also developing new onset diabetes after transplant. So when we think about our patients, one of the key aspects is once we pass that first year, we want to try to minimize all of those risk factors, and we want to try to improve their cardiovascular outcome and their kidney health as much as possible long term. So this is where some of these drugs come into play.
Okay, so these patients really carry a double burden, like the typical risks of diabetes and heart disease, plus then those added challenges that a transplant has with immunosuppression and maintaining that graft function. So, so now in the non-transplant population, these two classes of medications, the SGLT2 inhibitors and the GLP-1 receptor agonists, which we hear a lot about with mainstream media, social media. It's advertised a lot to a lot of folks online. These have been real game changers for diabetes patients and subsequently weight loss. Can you remind our listeners what they are and what we've learned from trials in people without transplants?
Yeah, so these two medications were developed for diabetes to help control blood sugars. But what we realized as we were studying these drugs in diabetic patients is that they had such a huge impact in lowering mortality of patients, in lowering cardiovascular risk, in lowering kidney complications, that suddenly, these drugs, from being a diabetic medications, they're moving towards not being used only in diabetics, but using beyond that. So how do we break apart these two drugs? So SGLT2 inhibitors are drugs that actually block the kidney reabsorption of sugar. So what ended up happening is that when you take these pills, you're going to be spilling more sugar in your urine. The consequences of that is that you're going to lower your overall blood sugar levels, and you may have some impact as well in dropping your weight and reducing your blood pressure. But where these medications have been a blockbuster is that they have been able to reduce cardiovascular complications in diabetic patients by more than 30%, which is it's unheard of, and there's no other treatment that it has been able to achieve that level of success. So there's a lot of still unclear reasons why these drugs have such an effect by just spilling more sugar in the urine. So there could be that there might be some impact on the innate immune side, that these drugs indirectly affect the immune system, reducing inflammation, and therefore we see a reduction in cardiovascular risk. But these are things that are still being worked up and investigated. But the benefit is there across multiple large randomized studies. The
Wow.
second,
So go
go
ahead.
ahead. No, go ahead.
I was going to say, so this population has reduced mortality, right? Like
Yes,
across the board.
yes, across the
Okay.
board. So that's the first class. And then, the second one is the GLP-1 receptor agonists. So now we hear them, on the news almost every day. And truly, again, these were drugs developed for diabetes, but the main effect was that GLP-1 shown a significant weight loss in patients. So how does it work? So these drugs are a little bit different. So they have to be injected. So they're not pills. But what they do is they act like a natural gut hormone that we have called GLP-1. So we have almost a hormonal communication between what you eat and then some signals that go into your brain that make you stop eating and tell you that you're full. So when you take these medications, it actually make you feel full faster. You have a slower stomach emptying, and you actually help kind of release insulin and control blood sugars, in addition to reducing appetite. So all that picture definitely helps improve blood sugar, but most importantly impacts weight loss. And when they tested the diabetic patients, they saw also this incredible effect in reducing cardiovascular mortality as well as reducing kidney complications. So suddenly these drugs that were developed for diabetes now are amazing at weight loss, but may have actually a huge impact as well in the heart and the kidney.
So the natural question is, do those benefits extend to transplant patients?
Yes,
Right.
exactly. And this is, well, go for it.
So let's dig into this meta-analysis that you've done. So
Yeah,
you pulled together a lot of studies, and ultimately that resulted in 32 studies with nearly 8,000 kidney transplant recipients. And that's a pretty big evidence base. So what were the main takeaways from what you found?
yeah. So, but I'll just make a one prelim, argument here is that all the studies that have randomized people to either SGLT2 inhibitors or GLP-1 receptor agonists in kidney patients excluded transplanted patients. So, there was a lot of lack of evidence out there in these randomized trials that there would be any benefit in transplant. And there are also some safety signals that have been appear in these trials, including, say, for the SGLT2 inhibitors, higher risk of urinary tract infections. For the GLP-1 agonists, there's some pancreatic and biliary complications that had been seen. So we know their transplant patients are very complicated. They come with a lot of comorbidities, and they also have all these other medications that they're taking that could potentially have interactions and so forth. So, part of us trying to gather all this data that's out there of studies that have been done in transplant patients is to understand what are some of the safety risks of using these drugs. And I think, of course, when you're comparing trials, and Macy has tons of experience on this, but you have the randomized control trial, which is your ideal study. It takes many years, many patients to get it done. But in the case of transplant, unfortunately, our patients were excluded, so we have to rely a lot on some of these retrospective analysis of the use of these drugs now in the clinic off label, so they're not necessarily indicated for transplant patients, but I think would allow us to actually have at least some understanding of how these drugs could potentially impact transplanted patients in general. So with all the hype on these drugs, we wanted to put together all studies that were high quality that have assessed the impact of both of these medications in kidney transplant recipients. And we looked at both at the potential benefits, looking at mortality, looking at cardiovascular events, looking at kidney outcomes, but also looking at the safety profile. So all these complications that we knew may happen with patients that are non-transplanted, could they happen at a higher rate in transplanted patients? Should we be more cautious in trying to implement that? And we cannot wait like 4 to 5 years for a randomized trial to at least have some sense of what's happening. And what's interesting as well is that I sent a survey to all like the main transplant centers in the US to see how many of them were actually using these drugs. And I'll tell you that, majority of centers have actually started incorporating these drugs into transplant care. And mostly in diabetic patients, but the possibility of even expanding, I think it's what some centers have been studying. So it was almost this timely, study to look back and see what is the data that we have so far. It's not ideal because it's retrospective, but it could give us some hint about, in particular, the safety and potential impact.
Okay, so let's get this straight. So both drugs, the SLGT2 and the GLP-1, they were linked to lower mortality, improved cardiovascular and kidney outcomes.
Mhm.
They promoted modest weight loss and improved, your hemoglobin A1C levels.
Mhm.
Um, the SLG2 also increased magnesium and reduced uric acid.
Correct. Mhm.
And most importantly, for our population of kidney patients, that the kidney function remains stable.
Yes.
So those are all real key findings. And I think when it comes to safety, there were no increased risks of infection use with the SGLT2 and no increased pancreatitis risk with the GLP-1. Wow. So you would say that overall the safety profile does look reassuring in this population based on the science that's been published to date.
Absolutely. Yeah. And I think if you quote the exact numbers, I think in particular in the benefit, if you look at SGLT2 inhibitors, there was a hazard ratio in one of the studies of 0.32. So that's like a 68% reduction in mortality risk, which is, quite large. And then similarly, looking at the GLP-1 receptor agonists, there was a hazard ratio of 0.39, which is also like a 61% reduction. The question that we always get is, okay, if each of these drugs have a major impact, what about if we combine them? And this data we still don't have it, but I think these are some of the next interesting questions. Do they have a similar effect, or are they complementary? And can you actually enhance even more the benefits of these drugs by combining? And truly, I think these are gonna need a bigger study with transplanted patients for us to fully elucidate that.
Very, very interesting. So this is kind of big. It's just huge, right? Because one of the biggest fears has been that transplant patients might respond differently, like a higher infection risk or worse kidney outcomes. But the data that you're able to publish here has not shown that. So I'm looking forward to the future research. So I have a couple more questions for you. And as a transplant clinician, you practice every day. You deal with very high risk patients all the time. You're excellent at your job. And so you're doing this every day. How does information like this influence your day-to-day care?
Yeah, so as we see the data coming out with some of these benefits, we as a team in our transplant center, we meet up and we decide, okay, how should we start deploying these new treatments to our patients? And you can think about, saying, oh, we should deploy to all patients, or you can say, okay, let's focus first on the high risk patients, and let's actually, do carefully on a stepwise approach. And this is the way we ended up deciding attacking this. So we enroll our patients in a research study. It's an internal research study in which we do careful clinical monitoring of these patients after receiving, for example, the SGLT2 inhibitors. And so they get initiated. We decided to wait until 6 months after transplant. And the reason that we wait is that early on, there's a lot of fluctuation in creatinine. So we want to avoid adding just another drug on top of all the others that they're taking and confuse the picture. So we wait for 6 months, then we initiate the drug, and we have a protocol of how we're going to follow up at least some more frequent blood work as soon as the medication is started. And so, and with these small, stepwise approach, we can learn how to best use the drug, also understand some of the issues or concerns, if copays are high from insurance, if there some other challenges that we may face implementing that. Because when we think about our patients, they already take a lot of meds, and of course you may tell them about all the excitement about how these drugs could impact them, but it's another copay, is another pill they have to take. With GLP-1 is actually an injection, and some insurances may actually not pay for it, and you may have a copay of $1,000 or $1,500 for the GLP-1 receptor agonist. So I think we have to think strategically about how to deploy that. Focus on high risk patients first, and of course we don't want to limit access to our patients, but as we move on to the clinic, to transplanted patients, we have to just be careful and think about strategically how we're going to deploy that in the real world.
Got it. So it sounds like we're at the point where clinicians are feeling comfortable considering these agents while also recognizing that the evidence is mostly observational and from these smaller studies of transplant patients, and that we need more studies. So what's next? What key questions do you think we still need to answer in transplant patients around these medications?
Yeah. So we discussed about the combination of drugs. I think this is a main question that still needs to be addressed and formally studied. The second one is we briefly touch on how these drugs have this incredible effect. So could it be impacting the immune system? And because the immune system is so important for transplant, looking deeply into the immune system as we start these drugs and seeing what impact they may have. Is it more on the innate side? Is it more on the adaptive? What are the changes that we're seeing that could potentially explain all this benefit? So understanding mechanistically how these drugs have this impact can also help us then to better deploy these drugs into patients. So I think that's a second important question for us to try to address.
That is that's really encouraging, and it's very clear to me that we have some gold standard trials that are still ahead of us in this
Mm-hmm.
space. And so I think, looking at long-term graft outcomes, potential interactions with all the other medications, as you mentioned, using them in combination together. What about whether the benefits extend equally across transplant subgroups, right? So maybe a type 1 versus type 2 diabetes, or early versus a late transplant patient, things like that.
Absolutely.
You see a
Yeah.
lot of research there.
Absolutely. I think, diabetes, diabetic patients in general, I think is the first big category that this is going to get deployed. But what we are seeing is even for the SGLT2 inhibitors, that in patients that have proteinuria, independent of diabetes, these drugs seems to actually reduce proteinuria over time. Don't ask me how, don't ask me why, but it has this benefit. And we know that, proteinuria is a surrogate in the sense that, the higher the proteinuria, the higher the risk of graft loss. So if you're able to reduce the proteinuria on these patients, you may significantly impact their graft survival. So there are things that we still don't understand. They seem miracle drugs, and I think we always a little bit skeptical about this, but across all the drugs that we have approved kidney disease in the past few years, which for the first time, it's more than a handful. These two drugs have been, really changing the landscape with this, hazard ratios that we haven't seen in any kidney study ever. And the hardest part is that we don't fully understand how are they making such a huge impact. But I think it's exciting, and I think for the young folks or those that are doing research, I think there's so much more that we need to understand about these drugs. And so I think definitely a lot of opportunities for all of us.
Awesome. Well, thank you so much. This has been such a rich discussion. And to summarize for our audience, the SGLT2 inhibitors and the GLP-1 receptor agonists have really already been proven to work and to decrease mortality in the general diabetes and chronic kidney disease populations. And they also appear to offer real cardiovascular and kidney benefits for the kidney transplant patients, with a very favorable safety profile based on this new meta-analysis from Dr. Riella's team. So I want to thank you, Dr. Riella, for sharing your insights and for leading this important work. We're really happy to have you on our podcast today.
No, thank you so much, Macy, and really excited to be part of this and pushing transplant forward. Thank you.
Fantastic. And thank you to our listeners for joining us. If you enjoyed today's episode, please subscribe, share it with your colleagues, and stay tuned for more conversations at the cutting edge of transplantation research with the Transplantation Podcast. Thank you very much.